Hi, this is Dr. Neurosurgery Greenberg, and we are continuing with the pituitary adenomas. Today, we are going to be looking at how to distinguish if the raised ACTH, the hypercortisolism, is from the pituitary or if it is from an ectopic source. And the first thing to do is random serum ACTH. If it is less than 5 nanograms per liter, 5 nanograms per liter, then it means that the ACTH is an ACTH independent Cushing syndrome, like an adrenal tumor. The cortisol is being secreted without any regulation from ACTH. Now, this is not a very sensitive value as the ACTH level can fluctuate. The next thing we do is, because we are suspecting that there might be some kind of adrenal tumor, we go for an abdominal CT, and it usually shows a unilateral adrenal mass with adrenal tumors, or it can be normal, or there may be bilateral adrenal enlargement in ACTH dependent cases. So, if ACTH is still in control of the cortisol, the CT abdomen may be normal, or it may even have bilateral adrenal enlargement. Next is high dose dexamethasone suppression test. Um, Phenytoin can interfere, many things can interfere with this test, but what is the main gist? What happens is that we give an overnight high dose of dexamethasone. So you first of all you get a baseline 8 a.m. plasma cortisol level. Then you give dexamethasone 8 milligrams at 11 p.m. and measure plasma cortisol level the next morning at 8 a.m. In 95% cases of Cushing disease, pituitary cause, plasma cortisol levels will be reduced to less than 50% baseline. Okay, if the cause is pituitary, the cortisol level next morning will be suppressed. But in ectopic ACTH or adrenal tumors, it will be unchanged because here they are not dependent on ACTH, right? So there is no feedback. It's just a tumor that is continuously secreting cortisol. After this, we come to metyrapone or metoprolol test. It is usually performed on an inpatient basis. What we do is we give 750 milligram metyrapone, which will again, just like dexamethasone, suppress cortisol synthesis. You can give it every 4 hours. In total, we have to give 6 doses. And most patients with Cushing disease will have a rise in 17-hydroxycorticosteroid in the urine, approximately 70% above the baseline, or an increase in serum 11-deoxycortisol 400 times above baseline. What Darabont test is doing is it is testing the hypothalamic pituitary adrenal axis, and in this way we are able to separate if the problem is coming from the hypothalamus and the pituitary, or if it is coming from the adrenal gland. What happens in a normal person is that 11-deoxycortisol gets converted into cortisol by the enzyme 11-beta hydroxylase. But in the case of metyrapone testing, this process is blocked, and in the morning when the patient wakes up, he has a low cortisol and a raised level of 11-deoxycortisol, which is a precursor of cortisol. Now, what happens in the case of a pituitary tumor? Then, in that case, you will see the same thing but in very, very high amounts. The precursor will be in very, very high amounts, okay? Because there is too much circulating cortisol, and also the we are going to see that the precursor is also very, very high because of the suppression. In the case of ectopic ACTH production, like an adrenal tumor, it is out of control of the hypothalamic pituitary axis. So it will work autonomously and we will not see these results. Next, we come to the corticotropin releasing hormone CRH stimulation test. So if you give exogenous CRH to a patient of Cushing disease in a dose they have given 0.1 microgram per kg IV bolus with even further increased plasma ACTH and cortisol levels. Okay, that is if the pituitary is secreting excess ACTH and leading to excess cortisol already, and if you give more CRH, the pituitary says, okay, I will make more ACTH and more cortisol will be produced. But in the case of an ectopic ACTH producing tumor, CRH, because again it is not under control, so it will not be bothered. Whatever it is doing, it will continue to do. Now coming to IPS, inferior petrosal sinus sampling. Some people even prefer cavernous sinus sampling. So what is done is that the interventional radiologist introduces a microcatheter to measure ACTH levels on each side, first at baseline, then 2.5 minutes, then 10 minutes, after stimulation with IV CRH. And simultaneously, peripheral ACTH levels are also being taken. So, first of all, IPS sampling is not needed when the following criteria of Cushing disease are met. If it is an ACTH dependent Cushing disease, if there is suppression with high dose dexamethasone test, and there is a visible adenoma on MRI, then you don't have to confirm where is the Cushing disease, okay? And second thing is that it may also determine likely side of a microadenoma within the pituitary. Thus may be able to avoid bilateral adrenalectomy, which requires lifelong glucocorticoid mineralocorticoid replacement. And there is also a risk of Nelson syndrome. So we can determine the side, okay, of the microadenoma within the pituitary. Sometimes there is a false positive test, and and it falsely lateralizes the tumor because of communication through the circular sinus. So if the both sinuses are communicating, then there will be false lateralization. And another thing you need to know is that a baseline inferior petrosal sinus ACTH to a peripheral ACTH ratio more than 1.4 is to 1 is consistent with primary Cushing's disease. So let's suppose in the left inferior petrosal sinus, the ACTH level was 1.4 times the baseline which you saw in the periphery. Then it means that this is a side where the Cushing disease is present. And a post CRH ratio more than 3 is also consistent with primary Cushing disease. And but you have to be very careful that the sinus wall isn't punctured. There is a 1 to 2% complication rate. You have to counsel the patient about that. But these are the results: CRH ratio more than 3, and IPS ACTH ratio peripheral ACTH 1.4 is to 1 is consistent with Cushing disease. So IPS is done when you cannot see the tumor. The tumor is so tiny that it cannot be seen on an MRI. It cannot be imaged. And it is so tiny you cannot even tell what side the tumor is on. But it is big enough to cause Cushing syndrome, Cushing disease. Okay, that is why IPS sampling is done. You cannot see the tumor, but it is producing very bad symptoms in the patient, and they need to be rectified as soon as possible. In the next video, I will be discussing how to check cortisol reserve, why it is important to check the cortisol reserve. So see you in the next video. Take care. Thank you.